Of the many important responsibilities carried by physicians and other healthcare professionals, an integral component of professional practice is preventing transmission of infectious agents within the healthcare environment. This includes patient-to-patient transmission, healthcare professional to patient transmission, and transmission from the patient to the healthcare professional. The transmission of infectious agents is a serious occurrence that has happened in many healthcare environments, including medical offices and clinics. The potential sources of exposure and modes of transmission are numerous. For example, patients have developed respiratory infections because healthcare professionals have failed to wash hands between patients, and because diagnostic or treatment equipment was not properly cleaned, disinfected, or sterilized. Healthcare professionals have become infected with HIV and hepatitis B from accidental needle sticks, and have become infected with tuberculosis by breathing air contaminated with infectious droplet nuclei spread by a patient. Every healthcare professional has the responsibility not only to ensure that the patients they care for are protected from infection, but also to monitor the infection control practices of those they supervise, and intervene if necessary to ensure compliance and safety. The importance of this responsibility cannot be overemphasized. Failure to employ accepted infection control measures not only increases the risk of adverse patient outcomes, but in the state of New York, formal charges of unprofessional conduct and other legal liabilities, including malpractice, may be filed. To help you increase your own awareness of your professional responsibility with regard to infection prevention and control, this program will present 3 cases for your consideration. As each case is presented, you will be asked to identify the possible source of infection, the means of transmission, and suggest what steps might have been taken. As you watch the scenes and consider the cases, think in terms of the principles of disease transmission and infection control, such as the 6 links in the chain of infection. Try to determine the pathogen. For example, it may be a bacteria such as a gram-positive organism like Staphylococcus or Streptococcus, or a gram-negative organism like Klebsiella, Pseudomonas, or Salmonella. It may be a virus, such as hepatitis B, HIV, herpes simplex, or varicella zoster. It may be a fungus, like Aspergillus or Candida, or a parasite, such as Entamoeba histolytica or Giardia lamblia. Try to identify the reservoir and the source. The reservoir is the place where the pathogens maintain their presence, metabolize, and reproduce. The source is the place from which the infectious agent passes to the host. The reservoir and source may be the same location, or the source may become contaminated from the reservoir. Reservoirs and sources may be animate, such as a human being with or without overt symptoms, or they may be inanimate, such as water, food, or a piece of equipment that has not been adequately cleaned and disinfected. Try to determine how the pathogen left the reservoir, that is, the portal of exit. In general, the major portals of exit are the respiratory and gastrointestinal tracts, as well as the skin and wounds. Pathogens can leave a human reservoir by means such as coughing, sneezing, draining lesions, diarrhea, drainage of body fluids, or withdrawal of blood. The actual portal of exit may not be immediately obvious. For example, while varicella lesions are highly visible, it is the airborne transmission that is significant. Identify the mode of transmission. It may be by direct or indirect contact with infectious material. It may be airborne transmission, such as TB bacillus disseminated by airborne droplets. Common vehicle transmission, such as from contaminated antiseptic solutions or contaminated multi-dose vials that are used for many patients in a single medical office. Look for the portal of entry. a natural or unnatural opening in the body, which may be the entry site. Portals of entry would include non-intact skin, mucous membranes, respiratory, gastrointestinal, or genitourinary sites. Also, determine the mechanism of introduction, such as inhaling organisms in the air or ingesting contaminated food, a percutaneous injury, surgical incision, vascular access, or other invasive means. Finally, think about the host factors which may increase susceptibility to infection, such as age, chronic disease, and immune suppression, which may increase risk. Identify factors which may improve host defenses and decrease risk, such as immunization. Careful examination of each of the 6 links in the chain of infection, the pathogen, reservoir, portal of exit, mode of transmission, portal of entry, and the susceptible host, should allow the healthcare professional to identify and utilize the appropriate infection prevention strategy. As you watch each case, try to identify strategies that might have been utilized to prevent transmission. Think in terms of first identifying what the infectious organism and its reservoir could be. If the reservoir is a person, could the reservoir be controlled by quickly recognizing the signs and symptoms of infection and initiating source control and treatment measures? If the source is an inanimate object, such as a piece of diagnostic equipment, was the equipment handled and cleaned properly? Was the agent used for disinfection appropriate and the contact time sufficient? Look for methods that could have been utilized to interrupt the mode of transmission. This is usually the easiest link in the chain to break. What role might hand washing or the appropriate application of aseptic technique have had? How about the use of barriers? Would gloves have protected the patient, healthcare professional, or both? Would the addition of a mask be appropriate? Would isolation of the patient with airborne disease have made a difference? What cleaning practices could have influenced the outcome? What about infectious waste management? Or linen and laundry management? As you watch each case, also ask yourself, what could be done to protect the patient or healthcare professional? Could the risk be eliminated by means such as vaccinations? How do we think about prevention? There are 2 concepts that are relevant. One is understanding the specific model of prevention that will be used, whether the diagnosis-driven model or the interaction-driven model. The other concept, hierarchy of controls, is a way of prioritizing and selecting the appropriate prevention model. The first concept applies a model of prevention. The models are determined either on the basis of a known or suspected disease, the diagnosis-driven model, or on the nature of the patient-healthcare professional encounter, the interaction-driven model. In the interaction-driven approach, infection control measures are based on the nature of the encounter with the patient regardless of diagnosis. Actions are taken in anticipation of contact with body substances that could transmit pathogens if the patient was a reservoir of those pathogens. In the past, infection control practices were primarily based on a diagnosis-driven approach. However, this approach does not provide adequate protection against inapparent infection transmitted by contact with infectious body substances, such as the blood-borne pathogens hepatitis B and HIV. Since infections may be inapparent, the interaction-driven approach has the advantage of ensuring protection all the time. Today, the application of the diagnosis-driven approach is primarily limited to preventing the transmission of airborne diseases, such as varicella and TB. Isolation measures taken for a patient with active pulmonary TB is an example of this approach. The second concept, hierarchy of controls, is a way of prioritizing the selection of prevention strategies. This is an industrial hygiene concept currently promoted by OSHA for the control of blood-borne pathogens. The hierarchy of controls model first considers what engineering controls could be used to remove or isolate a hazard and prevent transmission. Engineering controls would include equipment, devices, and instruments such as needleless IV systems, needle guards, and puncture-resistant sharps containers. Then, work practice controls, such as not recapping used needles with a two-handed technique, and point-of-use disposal are considered. Finally, personal protective equipment, such as gloves or masks, which could be worn as barriers, are identified. As you watch the cases and assess your own knowledge of infection control, note the areas where your own practice may be enhanced to better protect your patients, your employees, and yourself.
Yes, it could very well be chickenpox. You need to come in and see the doctor. The earliest appointment that I have is 2:15. Okay, 2:15. Charles Zuckerman. Okay, we'll see you then. All right, bye-bye.
Do you see the game last night?
Just the very beginning.
Yeah, it was a great game. Giants won 24-14.
Oh, yeah? Good game, huh?
Excellent. They're playing real good ball now.
Yeah, that's good.
Lori, we're ready for our next patient.
Okay. Charles Zuckerman, we're ready for you now.
Okay, take care.
All right, you too.
Would you like to follow me?
Yes.
Now, this pneumococcal vaccine will help reduce your risk for pneumonia, but you still have to be careful. The chemotherapy has lowered your white cell count, and any infection could be serious.
Hello, Dr. Madison. This is Dr. Welch, University Hospital, Emergency Department. I've just admitted one of your patients, a John York.
John York, yes, a lymphoma patient.
We suspect varicella pneumonia. He developed chickenpox a few days ago.
Chickenpox? I wonder where he could have gotten that.
With a disease as contagious as chickenpox, the chain of infection that led to Mr. York contracting the disease should be readily apparent. The pathogenic organism was the virus varicella zoster. The animate reservoir was Charles, the patient in the waiting room. The portal of exit was the respiratory tract. Airborne transmission occurred as droplets from respiratory secretions became suspended in the air and were inhaled by John. The portal of entry was John's respiratory tract as he inhaled the infectious droplets. The susceptible host, of course, was John, whose immune system was weakened by chemotherapy. This weakened immune system is a major factor in his becoming severely ill with a disease that does not usually affect adults. Although varicella is an illness primarily associated with childhood, susceptible individuals of all ages may develop severe illness and complications. This example clearly illustrates the importance of having all levels of office personnel understand and practice infection control strategies. Infection control begins with the first patient interaction. Clear communication between the physician and staff members is essential for this. What strategies might have been used to prevent this transmission? What about patient triage? Although triage is often thought of as occurring in an emergency department, it is applicable to any healthcare setting. One way to prevent transmission is to control the opportunity for infectious droplets to be spread into the air. Each person in the waiting area is a potential reservoir of infection. Observing for signs and symptoms and gathering other information that may indicate a communicable infection is the first step in this process. Of special concern are susceptible patients whose immune system is compromised for whatever reason.
Mrs. Edmonds, the nurse told me that your symptoms sound like chickenpox. Yeah, and since chickenpox is so highly contagious, we need to take precautions. Yes. When you come in to see the doctor, use the side door so we can take you directly into the examination room. Okay?
If there is a high degree of suspicion of chickenpox or other infectious disease spread by airborne transmission, Prompt isolation is essential. Telephone triage should be a part of staff training to help facilitate this. If isolation presents a problem,
I'm going to schedule you for the end of the day. How about 4:30? Okay. Yes. And the nurse will take you into the examination room right away.
scheduling can be used as an infection control strategy.
Excuse me, Mrs. Hatton. Here are some
yes.
tissues you can cough into.
Oh, yes, of course.
Be sure to cover your mouth and nose with the tissues when you cough.
I will.
I'll be moving you to an examination room as soon as one becomes available.
Oh, thank you.
To prevent the airborne transmission of infectious agents, the patient should be taught to control the route of transmission using the tissue technique, covering the mouth and nose with a tissue while sneezing or coughing. Also, they should be moved away from other patients.
Okay, Mr. Anderson. We're all finished. Thank you. This is ready to be disinfected.
I don't usually have this kind of problem. I think this is the worst case of diarrhea I've ever had in my life.
We've seen quite a few patients with these same symptoms lately. Maybe there's something going around.
Maybe.
Strange thing is, each one of the patients was in here last week.
Really? Let's pull the records on them and see if there's any connection.
Okay.
Three of these patients were in here last Thursday. Didn't we have a patient in here last week who had a culture that tested positive for salmonella?
I believe Mr. Anderson had a colonoscopy because of a complaint of diarrhea. Remember?
That's right. And his stool culture came back and tested positive for salmonella. Was he the first patient we saw that day?
As a matter of fact, he had the first procedure on Thursday. Do you think there's a connection?
Stool cultures obtained on Mrs. Smith and the other two patients did, in fact, grow Salmonella enteritidis. The incubation period was consistent with possible exposure during the colonoscopy procedure. Is this a likely case of cross-transmission? If Mr. Anderson was the source, what was the possible mechanism of exposure? The mode of transmission was probably the colonoscope. We are not yet sure how transmission occurred, but let's examine the possibilities. The portal of entry was most likely the lower GI tracts of the patients who underwent colonoscopy after Mr. Anderson. Were you able to identify strategies that could have been used to prevent these transmissions? Since the physician did wear gloves and did discard them and wash his hands after the procedure, this removes him as a likely source of infection. It may be that the cleaning and disinfection of the colonoscope was not done properly and therefore allowed for the transmission of these infections. It is the physician's professional responsibility to ensure that the reprocessing of the colonoscope is performed to the existing standard of care. This means ensuring that all parts of the colonoscope are cleaned and disinfected using an EPA-approved germicidal disinfectant and following the proper procedure according to the manufacturer's recommendations and the latest CDC guidelines. Water bottles and accessories that break the mucosal barrier, such as biopsy forceps, must be sterilized.
I don't think a K-wire will be enough. I think we'll need to do a plate insertion. Huh. I think I found a bone fragment. No? Well, glove's not punctured. Ranger, please. Let me know when she comes out of it, huh? I want to talk with her. Huh. That bone fragment must have really got me. I wonder if she's been tested for hepatitis and HIV.
The reason I'm here is that we're investigating a cluster of hepatitis B infections that have occurred in the community. Now, so far, none of the patients has had an identified risk, so we're exploring other possible sources of exposure. A few patients mentioned that they had had recent surgery or minor office procedures done by you. Now, this would include Michael Clydesdale, Martin Wyndham, Latonia Jefferson, and Helen Osborne. Do you recall any incidents where exposure might have occurred?
No, I can't think of any. Well, I might have been poked a few times, punctured gloves, but nothing memorable or out of the ordinary.
Do you know your hepatitis B status? Are you immunized?
Well, I've never had hepatitis, and I haven't been immunized.
Has anyone in your office had hepatitis B recently, within the last 4 to 5 months?
No, I don't think so.
Have you been ill any time lately?
No, I feel fine. Well, a few months ago, I was feeling pretty run down, but nothing that kept me from work, and there was no jaundice. Frankly, I don't know anyone who's had hepatitis recently.
Oh, what happened to your hand?
Oh, just dermatitis. It comes and goes. It's usually clear for a while.
Oh, I see. Well, Dr. Basil, as a part of the investigation, I'd like you to consider being tested for hepatitis B, as well as any healthcare workers who assisted or performed invasive procedures on the infected patients. Any help you could give us in identifying them would be appreciated very much. Now, in addition, I'd like to ask you a few questions on your office practices and operative techniques, as well as looking into procedures for cleaning and disinfecting. Some practices can put you and your staff, even patients, at risk.
Certainly. And I'll give my files on each of these patients a careful review. I want to help in any way I can.
Great, thanks.
Hepatitis B infection? And I'm surface antigen positive and core antibody positive? So that could mean the infection was fairly recent, right? And all the time I was worried about HIV. So did I get this from a patient, or did they get infected after their contact with me?
The chain of infection that led to the patient's contracting hepatitis B suggests several possible scenarios. To begin, the pathogenic organism was a virus, the hepatitis B virus. The efficacy of hepatitis B transmission can be very high. Even minute amounts of blood are sufficient to transmit the disease. While Dr. Basil may have acquired hepatitis B from a patient sometime in the past, the sequence of events and case findings suggest that Dr. Basil was the index case in this outbreak, his body being the animate reservoir. The percutaneous injury created a portal of exit for the virus, as blood from Dr. Basil was lost as a result of his finger being cut on the bone fragment. Also, his weeping dermatitis may have contributed to the transmission of the virus. The mode of transmission was inoculation with the blood from Dr. Basil, which carried the hepatitis B virus. The portal of entry in Mrs. Osborne's case was the open incision on her leg, which was contaminated with the physician's blood. The susceptible host, of course, was Mrs. Osborne and Dr. Basil's other patients. Dr. Basil had also been a susceptible host sometime in the past. All healthcare professionals should be informed and aware of the occupational risk for HIV and hepatitis B and the value of knowing their serostatus. And since it is not always possible to know when a healthcare professional is infected with a blood-borne pathogen, engineering and work practice controls to prevent patient exposure to the worker's blood should be routinely applied. But what is the risk of hepatitis B transmission from a healthcare professional to a patient? Being infected with a blood-borne pathogen does not in itself constitute a risk to patients. However, a number of reports have demonstrated that clusters of hepatitis B infections have been associated with infected surgeons, gynecologists, nurses, respiratory therapists, and general practitioners. But the potential for infection exists with any healthcare professional who has any contact with blood or body fluids. The proposed mechanisms of transmission in these outbreaks include intraoperative field Sharps injuries, exudative hand dermatitis, bleeding hand warts, contamination of intramuscular injections, and injuries from opening drug ampules. As you follow the chain of infection, you probably were able to identify prevention strategies that could have been used to alter the outcome. Proceeding in chronological order, first, one of the most important strategies for preventing hepatitis B infection is vaccination prior to exposure.
You just have to be careful and do everything you can to protect yourself from blood-borne diseases. At least this vaccine will protect us against hepatitis B transmission.
The vaccination should be given as part of a total occupational health strategy designed to prevent disease transmission by healthcare workers to patients and to protect healthcare workers from being susceptible to disease from patients. In this case, if Dr. Bassel had been vaccinated, it is possible all of the hepatitis B infections could have been prevented. Assuring immunity to certain communicable diseases is a vital prevention strategy. The state of New York and OSHA have targeted certain diseases for screening and immunization. These include hepatitis B, rubella, rubeola, and tuberculosis. In addition, annual influenza vaccination is recommended. Healthcare professionals should be familiar with the screening or immunization regulations and recommendations that apply in their work setting. What work practice and engineering controls could have prevented the patient's exposure to hepatitis B? In Mrs. Osborne's case, probing by hand in an area with poor visualization resulted in a stick incident. Injuries from such blind procedures, such as probing and suturing, can be reduced by using an instrument. The use of a small periosteal elevator to locate the fragment would have eliminated the opportunity for Dr. Bassel to cut himself on it. As mentioned earlier, new instruments and devices have been designed to prevent injury and should be incorporated into your practice whenever appropriate. What about personal protective equipment? Wearing protective gloves or double gloving may offer better patient protection after an injury because there is a greater probability that blood will be contained. This protection is also provided to the healthcare professional. While gloves will not protect against puncture wounds, they will diminish the extent of the exposure. Gloves are valuable in that they may reduce the volume of blood involved in the needle stick or other percutaneous injury. The controls mentioned so far may have prevented the exposure, but was there any prophylaxis that should have been given after the incident occurred? Responding to an exposure incident immediately and correctly can sometimes diminish or alter the severity of an illness. In this case, post-exposure management would have been appropriate for both the patient and the physician after contact with blood or other infectious fluids via a puncture wound, non-intact skin, or mucous membranes. Following the most recent CDC guidelines for post-exposure testing and prophylaxis for hepatitis B and HIV is part of your professional responsibility. Prophylaxis strategies should also include post-exposure evaluation and management. Blood tests for HIV and hepatitis B are recommended immediately after exposure for use as a baseline for exposed healthcare personnel and patients. Follow-up testing will determine if infection transmission has occurred. Take note that the type of accident portrayed in this case is serious. Hepatitis B is fatal in about 2% of cases, but the source patient could have been infected with HIV, where transmission of infection is virtually always fatal. Percutaneous injury has been responsible for most of the cases of HIV transmission to healthcare professionals in the workplace. Finally, Dr. Bassel had an inapparent case of hepatitis B, which is not unusual. While many healthcare professionals do not know their hepatitis or HIV status, the consistent practice of infection control techniques will provide a level of protection, even in cases where infection is inapparent.
Well, that's all I had to say. Anything else before we wrap it up?
Yes, I'd like to mention something. At the conference a week ago, there was a report about infections being transmitted via improperly disinfected instruments. I thought maybe we should do an assessment of our cleaning and disinfection procedures.
I think that's a good idea. You know, we probably should examine all our infection control procedures again. Because of news stories about HIV and healthcare workers, I've had some patients express concerns about disease transmission in the office. Now, I think if we all understand what we're doing, we can address their concerns more effectively while reducing risk and preventing transmission. Besides, we haven't done any formal review of our practice since the bloodborne pathogen standard was issued.
And that was before Jenny and Estelle came on board. And we've brought in a lot of new equipment.
That's right. The literature I've read indicates several factors that have contributed to most of the reported cases of infection transmitted by equipment. They include inadequate cleaning of equipment and exam areas, inadequate disinfection and sterilization processes, contaminated disinfectants or antiseptic solutions, reusing disposable equipment, and the failure to reprocess or dispose of equipment between patients.
There's a lot to look at, but I think making this assessment of our infection control procedures is important to this office. Now, to do it properly will take time, and I think we should divide up the project. Anita, since you mentioned it, would you look into our procedures for equipment and instruments?
Sure, I'll do that.
A thorough assessment of infection control practices can be a valuable tool in reducing the risk of infection transmission in any healthcare setting. Such an assessment would include an evaluation of the following areas: procedures for cleaning and disinfecting or sterilizing equipment and instruments, work environment issues such as between patient cleaning and general cleaning, the handling of sharps, hand washing practices, and the handling of medications, cleaning agents, and germicides. A comprehensive assessment would also include an evaluation of occupational health strategies, including periodic health assessments, immunizations, and an evaluation of illness and exposures.
Well, everyone's here. So it's been 2 weeks. How well are we practicing infection control techniques? Anita, you are going to look into procedures for equipment and instruments, right?
Yes, and by and large, we're doing pretty well. One thing I did notice, though, was that sometimes staff members clean differently or more thoroughly after HIV or hepatitis B patients. In fact, it seems that equipment is still cleaned more intensely after use with any patient with a known infection. But as we all know, this actually violates the very concept of universal precautions. It needs to be emphasized that all the procedures we utilize for disinfection are effective against HIV, hepatitis, salmonella, all the infectious agents we might encounter. The point is, we don't need other special procedures for infected patients.
To properly reprocess instruments and equipment, one first needs to know how to properly clean the device. Then, know the specific level of disinfection or sterilization required for safe use of the device. And finally, know how to achieve the required level of disinfection or sterilization. All medical devices are required to be sold with specific instructions regarding reprocessing methods. Proper cleaning requires the removal of organic debris. Hinged parts must be separated to expose all surfaces for cleaning and disinfection or sterilization. The level of disinfection or sterilization for a device depends on its use and can be categorized in one of 3 ways. Critical items are devices that are in contact with a vascular system or enter tissue, such as intravascular devices, surgical instruments, and instruments used to suture lacerations. These items must be sterile at the time of use. Semi-critical items are devices that are in contact with mucous membranes or non-intact skin, such as endoscopes, vaginal specula, and cystoscopes. These items should be sterile or receive high-level disinfection. Non-critical items are devices that are in contact with intact skin, such as ear specula, bedpans, and examination tables. These items should be cleaned with a detergent or detergent disinfectant to remove all soil and body substances, followed by the use of a disinfecting agent. After the method of reprocessing has been determined, selection of the appropriate agent of disinfection or sterilization process can be made. When making this choice, factors that might affect the integrity of the item must be considered. Manufacturer's instructions should be followed for the equipment under consideration. If a sterilizer is being used, the monitoring of all parameters is essential. For steam sterilizers, monitoring techniques include mechanical indicators, chemical indicators, such as heat-sensitive tape, and biological indicators, such as spore strips. Also, proper training of personnel is essential. They must be knowledgeable in proper loading and unloading of a sterilizer, proper packaging of items to be sterilized, and know the shelf life of packages after sterilization. Finally, single-use disposable items must never be reprocessed for reuse. Single-use disposable items are clearly labeled as such on their packaging.
Mary, you were looking at work environment issues such as the handling of sharps, right?
Yes, and in that area, we're doing quite well. Used syringes are routinely disposed of in sharps containers immediately after they're used. And no one is recapping them by hand, leaving them on instrument trays or counters. However, there are a couple of cleaning issues that I needed to bring up. There have been a few instances of contaminated instruments being cleaned in exam room sinks where hand washing is done.
Dirty instruments need to be placed in a container with a lid and taken from exam and treatment rooms to a dirty area in a cleaning room for reprocessing. Areas used for cleaning and decontamination procedures should be clearly identified and physically separate or separated from clean areas where instruments that have been cleaned or sterilized are processed and stored. Sinks should be designated by activity. Sinks used for hand washing should not be used for cleaning and disinfecting procedures. Likewise, sinks used for cleaning and disinfecting should not be used for hand washing after patient care. In addition to the obvious care needed for cleaning instruments, sound cleaning practices should be employed throughout the workplace environment. It is important that personnel are educated as to proper and effective cleaning procedures. Between patients, special attention should be given to surfaces which may have been contaminated by touch or splatter during an examination or procedure, such as overhead lights, countertops, and examination tables.
Another area I wanted to mention was hand washing practices. Even though we are constantly using gloves, they're not a substitute for hand washing. Hands should be washed before donning gloves and after gloves are removed. Gloves need to be removed as soon as staff have left a patient.
The most recent CDC guideline states that the recommended technique for routine hand washing is a vigorous rubbing together of all surfaces of lathered hands for at least 10 seconds, followed by thorough rinsing under a stream of water. Hand washing is still considered the most important single procedure for preventing infections. To ensure the effectiveness of hand washing, liquid soap dispensers are preferred over bar soap. Disposable soap containers are less susceptible to contamination than those that must be refilled. If refillable soap containers are used, they should be completely cleaned and filled with fresh soap when empty. Do not add soap to top off a partially filled soap container. If bar soap is used, purchasing small bars and using soap racks that permit water drainage will reduce microbial contamination.
I looked into how we handle our medications, including our use of multiple dose vials for injectables like pneumococcal vaccine. Multiple dose vials have been identified as vehicles for transmitting hepatitis B. We had 3 open vials and none of them were date labeled.
When using multiple dose vials, only one vial should be opened at a time, and the date that it is opened should be marked on the vial. Whenever medication is drawn up from a multiple dose vial, strict aseptic technique must be used. Be sure that only sterile needles contact the top and that the top is thoroughly cleaned with alcohol before its use. Syringes must also be sterile and never reused in any way.
I disposed of a multi-dose container of ophthalmic drops that I found with its top missing. Because we rarely use this medication, I recommend that we purchase it in single-dose units. A second area Dr. Gray wanted me to look into were cleaning agents and their use. Because Mary looked into cleaning and disinfecting procedures, we've been working together on this. We use cleaning agents and disinfectants for both environmental and equipment cleaning.
To prevent contamination, disinfectants and antiseptics need to be properly prepared according to the manufacturer's recommended use dilution instructions. Also, extrinsic contamination can be avoided by preparing solutions in a clean, uncontaminated area using a clean container. There are a wide variety of cleaners and disinfectants used in healthcare settings that will reduce the microbial load on inanimate objects. Before using a disinfectant, check the manufacturer's efficacy claims against the types of microorganisms the product is being used for. The Environmental Protection Agency requires manufacturers to list the microorganism its products are effective against and to register this information. Look for this registration. Disinfectants are not interchangeable, and an overview of the performance characteristics of each should provide the user with information to select an appropriate product for any item. Incorrect concentrations and inappropriate choice of disinfectant can result in the failure to completely disinfect an item.
One final point. I know some of you really like to use bleach for disinfecting, but it has its drawbacks. Its corrosive properties may damage equipment, especially when used undiluted or highly concentrated. When bleach is used, you must first clean off organic debris with a detergent before disinfecting with the appropriate bleach dilution.
Thank you, Jenny. Diane, you evaluated our occupational health strategies. What'd you find?
Let me begin by reviewing the goal of the occupational health strategies we have in place here. Our goal is to prevent the transmission of infections that we might pick up or carry to our patients and other staff members, and also to keep us from acquiring infections from our patients.
Comprehensive occupational health strategies include routinely performing pre-employment and periodic health assessments, immunizations of staff and screening for immunity, evaluation of acute or incubating illnesses, and post-exposure follow-up for needle stick injuries and other types of occupational exposures.
One thing I did discover was, while we've all been immunized against hepatitis B, we have been lax in finding out whether we are all immune to measles. And we all definitely need to get flu vaccinations and promote them to our susceptible patients. This flu season is predicted to be particularly harsh, and with all the elderly patients we see, the flu vaccine could protect us as well as them. Another area we should be careful in is coming to work with a minor illness. What seems minor to us could be serious to our patients. For example, a couple of weeks ago, I had a sore throat.
Are you feeling ill, Dr. Webster?
No, not really. I don't have a fever, but I woke up with a sore throat, and I wanted to be sure it wasn't strep, because I'm scheduled for surgery later. What did you need?
Oh, I found those files you asked about last night.
Oh, good, thanks.
Symptoms that should be evaluated by a physician before starting work include a fever with or without chills, a sore throat with a fever, a productive cough, rashes or vesicles, skin lesions, weeping dermatitis, draining wounds, open sores, and diarrhea.
Many times we can safely provide patient care by covering the affected area or wearing a mask. On other occasions, maybe we do need to limit patient contact or even stay at home until our symptoms resolve. Obviously, no one in this office would come in if they had an acute communicable disease like measles or active TB.
As hard as it is to stay home sometimes, I agree. It often is the best thing.
Practicing infection control is more than compliance with state law. At its core is the ancient enjoinder, primum non nocere. First, do no harm. This should be the first consideration for every healthcare professional and the motivation for every medical practice to serve its patients' needs.